Everyone. So today we're gonna give you like a presentation on preoperative care. We're gonna basically go over um, like some key points of a preoperative assessment and how to perform it, what's required as standard preoperative management, as well as the investigations that you're expected to complete preoperatively and why they're done. I think you're on mute.
There you go. So the management of preoperative patients is essentially a core function of junior doctors and placement medical students, and it fundamentally requires an assessment and management and the checking of basically patients' history, their health status, and whether they're suitable for surgery. So for some people, acronyms can be really useful, and so RAPRIP is one that we came up with. And the R standing for the reassurance, A, which is two A's for assessment and advice, P for prescriptions, R is for referral, I is for the investigations that are required, and then P is for patient understanding and follow-up. It's not necessarily important the order of which these things happen, but it's important that these are all covered prior to surgery. So patient reassurance. So it almost goes without saying as medical students that communication is key. And so you need to be able to convey ideas, thoughts, and equally listen to the patient's concerns. A key part of the conversation is building a rapport, because most patients do feel nervous or anxious about surgery, and you either need to say the right things to help them be more reassured about the procedure and whether they want to go ahead with it. Recognition of a patient interaction is just important for any sort of interaction, and it's just it's a standard, really good skill for ISCEs. So the preoperative assessment is essentially an opportunity to identify any comorbidities that may affect a patient during surgery, and identify if any patients may have any post-operative complications from either the anaesthetic, the surgical procedure, or even post-operatively after the surgery has been performed well. Patients scheduled for elective procedures will generally attend a preoperative assessment 2 to 4 weeks before the date of their surgery. So it's done nice and early, so if any changes need to be made, they can be. So what I'm going to walk you through is an effective history examination and the investigations that are required. And these are normally performed by an anaesthetist or the lead surgeon. NICE requires, essentially, which is why I've got this little image here, that in the preoperative assessment, you need to basically do a risk assessment and see which patients who aren't suitable, who are suitable, or patients who need further management, be it preoperatively with medications or fluid management, or those post-operatively at risk. For instance, the elderly are a prime example of a demographic that needs extra consideration. So one needs to consider perhaps doing a frailty assessment, and there are a number of different ones that hospitals use, but you would have to check the hospital guidelines when doing so. Okay. So part of an assessment is essentially a brief history, brief but detailed history, okay? You don't want to be missing any information. So as with any history, you start off with the history of presenting complaints. So what is the patient first, why did the patient first attend? And for what surgery are they requiring? What procedure? I think that's like the most basic question that a patient, that like a student can ask, or a junior doctor. And then you have to go through the different characteristics of the symptoms that they may be feeling. You need to double check essentially that there is a need for surgery and that they fulfill the criteria either set by the hospital or by the NICE guidelines. And you need to be able to then think, do I understand the pathology as someone who may be taking part in the surgery, that I will be able to do the surgery effectively? Okay, you also need to consider, which is something quite important, if it's a side related procedure. And what I mean by that, if it's a limb, then you need to confirm whether it's what side is affected and would be requiring surgery. There are numerous cases, as I'm sure you've all heard, of where there are surgery has been performed or procedures have been performed on the wrong side organ, be it the right kidney instead of the left one or the right arm instead of the left arm. So basically a history is a really good way to cover a clinician's back as well. Notation, you note everything down, and multiple times confirming something is good documentation. So then you do a past medical history. And this is, again, another really important thing preoperatively, because you need to ask about comorbidities and anything that might affect, essentially at this point, anesthetic and recovery. So cardiovascular disease, so in terms of hypertension, how is this managed? How does the patient manage it? Is it with medication or is there no need for it? If they live by themselves or if they are a resident of a home, do they have support there who monitor their blood pressure for them? What is their normal blood pressure? And then an important thing is exercise tolerance. So this can basically be a good identifier of cardiovascular fitness, particularly for patients who are undergoing major surgery. And it can be really useful to predict post-operative complications and the level of care needed after a patient has undergone surgery. Screening questions can involve anything from have you ever suffered with any heart problems? So very vague questions to more specific, like positional questions, such as do you have chest pain when walking? Do you have episodes where you feel faint? Do you have to sleep with pillows under your feet? Do you have any swelling around your periphery, so your limbs, so your legs and your ankles? Those can be all a good sign of any cardiovascular health risks or health conditions that may be undiagnosed. Then you have respiratory disease. Again, so you want to ask about positional symptoms, and oxygenation at the point, because essentially you want to reduce the risk of acute ischemic events at the point of anesthetic onwards. So questions again about are you able to lie flat? A really simple question which is often overlooked. Do you have like a chronic cough at all? As these can all indicate that spinal anesthesia may or may not be suitable. And then you want to screen for just general respiratory conditions. So obstructive sleep apnea can be a good one, because it's indicative of a poor airway, which may put a patient at risk when given anesthetic, and any other risk factors, okay, for respiratory disease. And then you have renal disease. Which assesses baseline renal function and is really, one second, I think one of you is okay. 1 second. I'm just going to do something, sorry. Okay, sorry about that. So let me go back to that. Renal disease, basically baseline renal function are really good at getting a long-term picture of the patient's health, and if any medication that they may have been on long-term has affected their general health. And then endocrine disease, specifically you want to ask about diabetes and thyroid problems. Those are the two main key conditions that you want to ask about and you don't want to forget, because as most of you are probably aware, type 2 diabetes or type 1 diabetes can cause a lot of complications in terms of prescription of medication prior or after a surgery. And then a really important one, which some people don't think about, is GORD, so gastroesophageal reflux disease. And that's because there's obviously an aspiration risk with anaesthetic. And it is a really key question that anaesthetists ask about. And a lot of questions will, I know that on some MCQ questions in previous exams that I've sat anyway, have always asked about what condition do you have to ask about, which is important for an anaesthetist, and that's normally GORD. And then blood diseases, so obviously anything that may make you question whether you give certain blood products, so anemia, sickle cell disease, are worth asking about. And then importantly for women with any sort of history, you need to ask about a pregnancy status. Some majority of surgeries will not go ahead if a woman is pregnant, not unless there's specialist consultants in place to deal with the mother and the child. So then you move on to the past surgical history. So the things that you want to be asking is, have you had any previous operations? And if so, what were they? When did they happen, if you can remember? Whereabouts were they? Often some patients move houses and different districts, so like health boards, so you have to sometimes request notes. And why did you have the procedure, your previous procedure? Was it to treat this to treat the condition that you're currently going to have another procedure for? If so, we need to then question whether a repeat procedure is worth having and whether the risks are okay for the patient. And then you have to then think about anaesthetic. So you want to know, have they had previous use of it? If so, how did they react with it? Did they have any problems? Things you really want to be asking about is any sort of allergies or any airway difficulties, and then nausea and vomiting, and then post surgery, or even if a surgery didn't happen. You basically want to be asking questions that would help you decide whether the answers, would impact the surgical time, so the time spent in surgery, and whether it'd be an easy surgery if it was to go ahead, and whether the surgery is worth the risk to the patient as well. Okay, and then you want to do drug history. So this is something that I will go and talk about further in greater depth, but the basic things that you will have to cover is the current medication that they're taking, any stopped medication, be it off their own accord or with advice or anything that they've read online, and whether they have any allergies and what type of allergy, like a reaction you get. That's a really sort of high class answer if asked by a clinician. So do you have an allergy? Yes. What type? Does it cause an anaphylaxis, or do you get skin rashes or feeling nauseous and sick? Because that can sometimes impact an anaesthetist decision whether they use a certain medication or not. And then a family history. I know that it's a less important part of the history, but it's still worth considering. So some hereditary conditions do impact anesthesia. One such condition is malignant hypothermia, and basically it's a condition that affects a patient when they have certain gases or an anesthetic or muscle relaxants. And signs of malignant hypothermia would include like signs of shock, essentially. So raised blood pressure, a raised heart rate, acidosis, and then muscle rigidity. So like very, very rigid, essentially. And then, so the treatment of malignant hypothermia, if that were ever to occur, would be removing of the offending agent and normalizing vital signs and maintenance of temperature. So yeah. Any questions? If so, put in the chat. Okay, no questions. Fine, okay, I'm going to carry on. So the last point of a history, like all of you I'm sure are aware, is social history. Smoking, alcohol and drug use are just standard. Smoking and alcohol use are obviously risk factors for a number of comorbidities. It also gives you an idea of patients' like health status and fitness. And then language is something that's often overlooked. If you're the student that's been asked to consent a patient for a procedure, or you're a junior doctor at this point, you need to make sure that a patient is able to understand you. Do you need a translator present? Do you need to have things written down and give leaflets? So these are all sort of things that you need to consider. And then obviously a living situation is obviously different for each patient, but you need to think about post-operatively, once a patient is discharged, is there someone who's going to support them at their home? Are they able to do it themselves? Or are we going to have to organize a package of care? So a sort of package where we send them to certain, like a residential home or a nursing home, to accommodate for this patient during this period. Okay. Now we're going to move on to, examinations that are required. So you have I've split it into 3 key examinations. You basically need to do a head-to-toe examination. So you need to do a general one, essentially, to identify any underlying undiagnosed pathology present. Okay, and that includes the cardiovascular, respiratory and GI signs that you're looking for. Okay, and then you want to do a specific region or site examination. So if you are wanting to do an ankle surgery, you need to examine the ankle itself, note which side it is, and often the surgeon or the anaesthetist will have a marker and mark the ankle to reduce risk of any mistakes happening. And then you also want to look for signs of infection. If so, we might want to then give prophylactic antibiotics earlier, or different types of antibiotics, or they may even delay the surgery. And then you want to consider doing an airway examination. So the two that are known that a student would be expected to know are the Wilson score or the Mallampty score. So the Wilson score is essentially just a pro forma in which you fill out according to the patient, and it's to assess general the general health of a patient and see whether an airway can be managed successfully or not, and what sort of management might be more useful. Okay, and so the scoring system here, so a score of less than 5 suggests easy laryngoscopy, and then a score of 5 to 8 may be potentially difficult. So anaesthetists may want to reconsider if, for instance, they were going to let their registrar anaesthetist to do it. They may think, oh, I'll do it myself. And then 8 to 10 score is actually, is it worth risking a surgery because the airway can't be safely managed. The Mallampty score is used to predict the ease of endotracheal intubation. So that's when you put the metal, I don't know if any of you have seen surgeries, but a metal device at the back of the throat to pass down an air, a tube essentially down. And the test essentially comprises of a visual assessment. It's only observational, and to work out whether there is enough amount of space in the mouth itself to actually perform the procedure and to safely put in a said tube. So yeah, there's something in the chat. Why do respiratory conditions mentioned in the past make the patient unsuitable for spinal anesthesia specifically? I'm not too sure. That's the honest answer. I was just told that spinal anesthetic can be more difficult if a safe airway isn't present. So I may have to get back to you on that one, sorry. Not unless anyone else can answer that question. And then the ACE score, I'm just about to go on to that now. So the ACE score, so it's the American Society's anesthetic grading, and it's basically used to stratify the risk of a patient based on their health. And it is, you won't see a WHO checklist for surgery without an ACE grading. It's really important, not just for the anaesthetist, but also the technicians and the operating staff, nursing staff, just so that they can prepare the right equipment and any other equipment that they may need if anything were to go wrong. It's a subjective assessment, and it's evidence-based, so it directly correlates to post-operative complications and absolute mortality, which is why there's such a stress of importance for it. And then there are other scores which are less often used, but they may be used depending on the clinician that you're with. But a surgical severity score can also be used, and that's essentially used to grade the need and the urgency for a surgery quite objectively. It doesn't take into consideration other comorbidities or other factors, so it is very much less used. But as I said, a grade can be given in the case that there may be prioritization of patients, if you have a backlog of patients who've come in as emergency for whatever reason, and then you can grade them and do the surgeries as according to the grades. And then there are other scores which are worth mentioning, but they're more specific for certain surgeries. So you have NELAs, and then you have SORT and POSSUM. But I think the one that's worth knowing for exams and for your practical exams, be it OSCEs or ISCEs, is ACE grading. Okay. Next. So RAPRIP, we've gone back to it. So we've done the first A, and then the second A is advice. So you've done the preoperative assessment, which was done, let's say, 2 to 4 weeks ago. You now want to advise the patient for when they are about to come in for their surgery. And most information that's given is regarding fasting. Now, there's always going to be a question on MCQ exams about fasting usually, because it's just one of those things that rarely changes. It hasn't changed since I've been at medical school. And it's just one of those things that they can know that you either know it or you don't. So you have to stop eating 6 hours before. Dairy products are 6 hours before. And then clear fluids, however, are 2 hours before, okay? So no patient is allowed tea, but 2 hours before surgical admission, despite how much they may want it. And then some of you might be thinking, why do we need to fast? So basically, by fasting, you're ensuring that the stomach is empty, and it reduces the risks of aspiration, essentially, which, like I said, is a complication that anaesthetists want to have to preempt. If a patient does, for whatever reason, eat in that fasting period, they will be delayed, if not rearranged, particularly if it's an elective surgery. So it's in the patient's best interest to follow the fasting guidelines. So now I'm moving on to prescriptions. Now this is more of a summary page of what I'm about to go through and the key things that you should really follow when thinking about medications. But essentially, preoperative management of medication falls into 3 categories: drugs you want to stop, before surgery, the drugs that you have to alter before surgery, and the drugs that you need to start before surgery. Obviously, in certain patients, depending on the surgery, you may need to prepare for blood products to be used. You need to prepare for bowel preparation. So those are other things that you need to consider. One thing that I'm just going to cover quickly is that the starting of drugs. So TED stockings, these will be given to all patients, and with the exception of vascular patients. So any patient that's requiring vascular surgery will not be given TED stockings. And then they are essentially below the knee socks that need to be prescribed unless they are contraindicated. You can find the contraindications in BNF, but like I said, severe peripheral vascular disease is one of the key contraindications. So do not ever prescribe TED stockings in peripheral vascular disease. And then antibiotic prophylaxis, I mentioned this earlier. Patients who are having orthopedic or vascular or GI surgeries will often require prophylactic antibiotics, generally because they're quite dirty. I say dirty, but they're quite heavy germ-related surgeries. And they will be prescribed either by the anaesthetist or the surgeon, which is why allergies is really important to get in the pre-operative assessment. There are some questions. Okay, so Zaina's answered that. Okay. So I'm going to talk particularly about antiplatelets and anticoagulations. Anticoagulants, sorry, because they are often things that are asked, and there's a lot of confusion, particularly when to start them, when to stop them before surgery. So clopidogrel is an irreversible platelet inhibitor, and so it needs to be stopped. That is one of the key drugs. You have to stop clopidogrel before surgery. Okay, so irreversible platelet inhibition, and so you need to stop it 7 days before. Okay, in terms of other antiplatelets, you have aspirin, dipyridamole, and NSAIDs. You can continue those as normal according to the patient's prescription. However, if for whatever reason yourself, if you're a clinician or your supervising clinician believes that there's a reason to stop them, you stop them. Okay, and as I've mentioned here, it's normally due to renal function being impacted. And then in terms of anticoagulants, warfarin needs to be stopped 5 days before surgery due to the risk of bleeding. Okay, so it's definite 5 days, but the last dose should be taken on the 6th day prior to procedure. Okay, for minor surgeries, it doesn't need to be missed, but that's up to the clinician. As a student, learn it as you need to stop warfarin. In emergency surgeries, you need to have on standby reversal agents for warfarin, which are vitamin Ks, and you need to check INRs to make sure the ratio is within the right range. Okay, that is a given for any emergency surgical case that comes through. Oh, sorry. Oh, I don't know why it's gone so far ahead. There you go. And in terms of heparin is a short-acting and unfractionated, and so it's normally given via an IV infusion. Okay, it must be stopped 4 days or 4 hours, sorry, before any sort of spinal anesthesia is given. Okay, so that's either an epidural spinal anesthesia, okay, spinal block. And APTTs need to be monitored. In terms of low molecular weight heparin is a longer acting medication, and if it's ever given, it'll be through subcutaneous preoperatively, okay? And then you have NOAC, so novel oral anticoagulants, and there are a number of different ones, but the three main that I'll talk about is apixaban, dabigatran, and rivaroxaban. So rivaroxaban clearance is dependent on dose and renal function. So you need to prophylactically give a dose when they have a creatinine clearance of a certain level at 18 hours before, and then a treatment dose 48 hours before. So essentially the first dose that you'll be giving is 48 hours before if need be, okay? And then with dabigatran and apixaban, you give 48 hours before any spinal anesthesia, or any anesthesia really. Okay, question? Okay, right, fine. So diabetes, given in this sort of population and the time that we live in, diabetes is becoming more prevalent. And so you need to be prepared to have a diabetic patient ready for surgery, okay? So the management is dependent on whether they're type 1 or type 2 diabetic. So for all type 1 diabetics, they should be the first on the morning list, and they need admitting the night before, okay? Before any operation. Well, and that is obviously dependent on the surgery or the procedure, but they should be first on the list nevertheless. So on the night before surgery, you have to reduce their subcutaneous basal insulin by 1/3. And then the morning after, you stop their normal insulin and you begin an insulin sliding scale infusion pump. And you do that according, most nurses will set that up and be on it. So it's definitely worth, if you have surgical placement, watching them do it and how they do it, and they may let you do it. And then whilst they're nil by mouth, the patient needs to be prescribed an infusion of 5% dextrose and at an approximate rate of 125 milliliters per hour. But the important thing here is they need the sugar, so they need that 5% dextrose, okay? They need regular checking of their BMs every 2 hours, and this continues until the patient can eat post-operatively, okay? So this will be prescribed for a patient throughout their surgery as well. A patient, once the patient can eat post-operatively, there has to be an overlapping period in which that insulin pump is given and their normal insulin is given per their normal daily routine, okay? So there's an overlapping period where they will be getting 2 amounts of insulin and just in different forms. In terms of type 2 diabetics, it's very patient-centered. So it's dependent on how the patient monitors their diabetes, okay? So diet controlled, you don't need any action preoperatively. However, with any oral hypoglycemics, so any really diabetic medications, they need to be stopped. So metformin is stopped on the morning of the surgery, and all others are stopped 24 hours prior to surgery. In terms of insulin, patients will be given insulin any patient who was on oral hypoglycemics will be assessed whether they require insulin, and then they'll be started on an IV insulin sliding scale, which they will be on throughout their surgery, and then post-operatively it will be weaned off and continue their normal medication. Oh. Okay, any questions? Okay, fine. Okay, so other medications to be consider is the contraceptive pill, so hormone therapies. Contraceptives, as you all are probably well aware, that they increase the risk of deep vein thrombosis or PEs or clots in general, especially in people who are immobile or have or exceed normal weight BMIs, okay? So the oral contraceptive you have to consider is ones that are estrogen, mainly estrogen. They have to be stopped, okay? If Other like progesterone related contraceptives can be continued, but they need to be mentioned to the clinician, and it's up to their discretion whether they say to continue it or not. Tamoxifen is one worth mentioning. That's often, again, comes on MCQs. So breast cancer patient is on tamoxifen, is about to have surgery. Do they stop it or not? Well, it's about measurement of a risk assessment, essentially. Does the benefit of the surgery outweigh the risk required in stopping or interrupting the regime of tamoxifen? Okay. And then steroids. This is a key learning point, which a lot of surgeons I know on placement ask. But essentially, if you have a patient who has been taking steroids for longer than 2 weeks, then they need to continue it through their surgery. Okay. Essentially, the dose of most patients, anything above 5 milligrams of prednisolone, will need to be given during the preoperative and postoperative period. Okay. But a steroid regime is normally shown on the BNF, so you can normally look that up at the time. And the reason that you have to consider it is that surgery in itself is a traumatic experience for the patient. Physically, it will elicit a stress response, which is responsible by the hypopituitary adrenal axis, and that will be activated and increase endogenous corticosteroids such as cortisol. Okay, steroid therapy essentially causes a suppression of the endogenous corticosteroids that your body naturally produces. So if you were to stop it immediately, then you would be at risk of adrenal insufficiency and actually cause an Addisonian crisis. So what you do is any patient with steroid therapy for greater than 2 weeks, you give them a short synaptin test to confirm whether they are adrenal insufficient prior to the surgery, and then you will prescribe accordingly whether the dose of steroids required. Again, there is no exact amount, and it is normally based on on the clinician's experience. But what they will do, if a patient can't tolerate oral steroids, for instance, if they were normally on injections, then they can switch it to IV. Any questions? The reasoning for type 1 diabetics being first on the morning surgery list is because you need to prepare them for subcutaneous, you need to reduce their subcutaneous insulin the night before. So most patients are started in the morning so that you reduce it, then you can make sure that they don't take their normal morning insulin, and that insulin sliding scale can be started straight away. Because with type 1 diabetics, they're very they're reliant on the glucose, and ensuring of the fasting period is affected as well. So you want to essentially, for it to move smoothly, you need to have the patient on the morning list. So you will take them, admit them, the night before, stop or reduce their normal insulin by 1/3, and then that you will stop their morning normal regime. So it's basically to stop that normal regime in the morning. I hope that answers your question. Antibiotic prophylaxis are the GI, orthopedic and vascular surgeries. Those are the most, but you'd have to check the hospital guidelines, because some surgeries do require it, like some obstetric and gynecology require antibiotic prophylaxis beforehand as well. Okay. And then just a quick little summary on other medications to consider. So monoamine oxidase inhibitors, they can interact with anesthetic drugs. So anaesthetist may say they need to be stopped, or he or she may consider to keep them going. Lithium levels need to be monitored, particularly drug concentrations and the effects on renal baselines. And then antiarrhythmics and antihypertensives. ABD is how I remember it. So ACE inhibitors you withhold in the morning. Beta blockers, you continue unless told otherwise. And digoxin, you need an ECG beforehand. Okay. And then finally, bowel preparation. This is obviously only specific to certain patients, but it's basically to clean the colon out before bowel procedure. Certain procedures will require bowel preparation than others. So for instance, if I were to take upper GI or small bowel surgery, nothing is required for that other than the normal surgical advice, whereas an anterior resection requires 2 sachets of Picolax, which is a laxative, the day before, or an enema the morning of. Okay, so that needs to be prescribed as well, which people don't necessarily think about or consider. And then obviously when prescribing anything, you need to think of contraindications and which demographics should be given them or not. So it's less frequently used for the elderly, cardiac and renal patients, just because it can be harmful and there are a number of contraindications and adverse risks to them. And it can prolong recovery and patient length because it often dehydrates a patient. Okay, any questions? No? Okay, I'm going to move on. So Zaina, your turn.
Yeah, so I'm going to talk about fluid prescription. So fluid is mainly prescribed fluid is mainly prescribed for 3 reasons: maintenance, resuscitation, replacement, and redistribution. So for resuscitation, that's usually when someone has lost a lot of fluid, either through a major hemorrhage or if they're in shock. So their vessels, that's when the vessels don't retain their normal tone, and you have low intravascular volume, which needs to be replaced. And for that, you usually give a fluid challenge, which I'll talk about in the next slide. For maintenance, that's just replacing someone's normal physiological need, and usually match the daily electrolyte requirements, which NICE guidelines suggest is 25 ml per kilogram for water, 1 millimole per kilogram per day for sodium and chloride, and then 50 grams per day for glucose. If you go on to the next slide. So there are 3 types of fluid. There's crystalloids, so that's just basically normal saline. It's to expand the extracellular volume, and it's usually first line for resuscitation, hypertension, and hemorrhage. And then you have colloids. Colloids are usually gelatinous solutions. So they're like albumin, and they were initially used for resuscitation, but actually new research papers have shown that crystalloids are just as effective. Blood products are considered a type of fluid, and we'll talk about that in the next slide. And then also, if you just look at the table, you can see that there are different like types of crystalloids and colloids, and you prescribe each one depending on the patient's condition. So for example, with saline, you can see that it just has sodium chloride, whereas with Hartmann's solution, which is also lactate ringer, you have things like potassium, calcium, and lactate as well, and it more closely matches the osmolality of your plasma. If you can just go to the next slide. So fluid deficits are corrected differently for different patients in different circumstances. So usually everyone's meant to maintain normal urine output of 0.5 ml per kilogram per hour, and that's as a minimum. So anything less than that, then you need to manage aggressively with a fluid challenge. And a fluid challenge is just 250 ml or 500 ml of either saline or lactate ringer over 15 to 30 minutes. And it's just to replace the ongoing losses. And you also need to consider patients who have lost fluid that's not really visible. So if someone isn't acutely bleeding, they could also have lost fluid either by sweating or by having diarrhea or vomiting. So that's just something to keep in mind. And we can just go on to the next slide. So blood products are also a type of fluid, and with blood products, there are nice guidelines for people who are eligible for red blood cell transfusions. So these are people who had major hemorrhage, sometimes people who have acute coronary syndrome, or people who have a hemoglobin level less than 70 grams per liter. And you should aim for a target of 70 to 90 grams per liter after the transfusion. There are a few blood tests that need to be performed prior to the transfusion, and that's just to make sure that the patient doesn't develop an allergic reaction to the blood due to like blood groups not being matched correctly. So there's group and save and cross match, which you'll commonly hear on the wards. With group and save, it's done in non-emergent situations, and it's basically to determine the ABO blood group and the rhesus status of the patient, and it's also to screen for any atypical antibodies. And then you have cross match, which is basically physically matching a patient's blood with a donor match to see if an immune reaction occurs. And this is usually done if blood loss is anticipated, but a group and save needs to be done prior to that, just to determine the patient's blood group. And then obviously, if it's an emergency situation, the patient is unconscious, they're unable to tell you their blood group, and there's no time to perform these tests, then you would give O-neg. Before prescribing, you should use the 3 points of identification to make sure you're giving the right medication to the right patient, or the right blood product. So you should check their name, date of birth, their number or address. You should obtain consent, label the bottle at the bedside, and complete the transfusion request at the bedside as well. And if you can move on to the next slide, please. So each blood unit needs to be prescribed individually, even if the patient requires more than one transfusion. That's just to make sure that, again, no mismatch happens with the patient's blood type. And blood products are only administered by a green or gray cannula, and that's to prevent the cells from hemolyzing. So you want to make sure you have a large bore cannula to make sure that the red blood cells aren't sheared from narrow tubes. And you should also carry out basic observations before the transfusion, 15 to 20 minutes after it's started, at 1 hour, and then once the transfusion is complete. And usually NICE recommend a single red blood cell unit transfusion for surgical patients who don't have any active bleeding. And they advise that all blood products are given by a blood giving set rather than a normal fluid giving set, because it has a filter chamber. So there are different types of blood products, each with a different indication. So packed red blood cells are usually given for people who have symptomatic or chronic anemia, so kind of like how we discussed before, hemoglobin level less than 70, or people who have cardiovascular disease and that threshold is less than 100 grams per liter. They can also be given in acute blood loss, and packed red blood cells are usually administered within 4 hours of coming out of store. So somewhere between 2 to 4 hours is typical for packed red blood cells. For platelets, they're given in people who have hemorrhagic shock, so someone who is hypertensive, they've lost a lot of blood, or someone who has a low platelet count, so that's thrombocytopenia, and it can be given someone who is bleeding or not bleeding, and it's administered over 30 minutes. Fresh frozen plasma is basically clotting factors, and it's given to people who are in DIC, so disseminated intravascular coagulation, which is just basically a consumptive coagulopathy, where your body consumes all the clotting factors and you just start bleeding. It can also be given for massive hemorrhage, or hemorrhage secondary to liver disease, where you're unable to produce your own clotting factors. And it's also given over 30 minutes. And the last one is cryoprecipitate. I think it's there's a typo in the slides. We'll make sure to fix that. And that's basically frozen, and it's composed of fibrinogen, von Willebrand factor, factor VIII, and fibronectin. So also things involved in the clotting cascade. And it's also given for DIC, von Willebrand disease or massive hemorrhage, and that's usually given stat, so not over a period of time.
Okay, so going back to wrap-up, so we've covered the reassurance, we've covered the preoperative assessment, we've given the advice, we've given the prescriptions of what be it medication, blood products, fluids, and now you want to do the R, which is the referral. So you need to basically consider where the patient is going to be managed, and you need to inform the staff and book it. Okay, it's a process, it's a simple process, but it's something that needs to be considered, and you need to think about post-operatively based on your preoperative assessments. Is this patient likely to have a post-operative complication? If so, an intensive care unit may be needed, whereas if this is a minor surgery and the general practitioner, the GP, is able to perform the surgery themselves quite quickly and there's no complications associated with that surgery per se, that it can often be managed in the primary care. Okay. Then you have the investigations. So the basic ones you need to think about are vitals. You need to rule out sepsis, so you follow the sepsis 6 if need be. Then you do the check the respiratory rate and the oxygen saturation. Basically tells you the baseline respiratory function, and whether an airway assessment is like part of the airway assessment essentially. Temperature, again, I said it, part of sepsis. And then blood pressure and heart rate is to help with basic baseline cardiovascular status, because at this point what we've only done so far is a history and an examination. So these are some objective results that you can have. Urinalysis to rule out a urinary tract infection and therefore prevent of any sort of infection risk in the surgery itself. MRSA swabs, again, that's something to rule out infection, and if that is present, then you need alteration to the antibiotic prophylaxis given if found positive. Given the day and age that we are, COVID swabs need to be done, and adhering to the current guidelines at the time, whatever they be. And then weight is important for an anaesthetist essentially, because then it's to not only assess the quantity of anaesthetic required, but also it can be a good sign of their airway management. And then, and then a BM, so particularly for type 2 diabetics and type 1 diabetics, you need monitoring of their daily glucose levels to ensure that it's managed correctly. So those are sort of the basic standard bedside assessments that you can do. Then in terms of investigations, bloods are required, okay? So you look at the order of draw whenever taking any bloods, but essentially blood tests required would be FBC for anemia and thrombocytopenia checking, U&Es for baseline renal functions and electrolyte abnormalities. That can influence obviously the prescription of blood fluid medications, whether you give Hartmann's over saline. Then you've got LFTs, so liver metabolism and synthetic function, particularly useful if a patient has a comorbidity related to the hepatobiliary system. Then you have HbA1c, that's really important for type 2 diabetics, as it gives a long-term assessment of their glycemic control. You have clotting screens, so a coagulation assessment, particularly for patients who are taking anticoagulants and antiplatelets. And then you have the group and save. So group and save, as Zaina said, it's for identifying blood groups and antibodies. No blood is issued from taking a group and save. So you don't prescribe blood as a result of a group and save. You require a cross-matching one, which is often in pink, bottle, which is where it can match the correct donor products for the patient, and that's when a blood products can be then prescribed appropriately. And then standard system investigations that are required go through cardiac, respiratory, and abdominal. Obviously, some are more important depending on the surgery that is expected to be performed. Then ECG is a gold standard for majority of patients. It's mandatory for patients over the age of 50, and there's nice guidelines on it. It's not something that you'll be assessed on or asked about, but it's worth noting that it's mandatory for those over 50. It's specifically that rule can be negated if a patient has a history of cardiac disease or had previous open surgeries, or has a history of like a family history of sudden cardiac death. An echo can be really useful, but that is unique to a patient, and it's tailored by the anaesthetist, and it allows intraoperative care, so within the surgery itself, to be tailored, because using an echo can allow anaesthetists to make any changes if there are signs of heart murmurs or cardiac failure, essentially. For patients with untreated ischemic heart disease, which can often don't present on examinations, myocardial perfusion scans can be quite good at looking at undiagnosed or unidentified ischemia. And then, like I said, cardiopulmonary exercise testing can be really useful, particularly for major surgery. And it's essentially getting a patient to do exercise and increasing the intensity over a period, and watching and monitoring their ECG to see whether there was any changes or any worrying factors. Then respiratory system investigations are looking at chronic lung diseases to assess postoperative pulmonary complications, which essentially means you're looking at your spirometry and for any signs of COPD, look at their respiratory baseline and see whether they are able to breathe appropriately and to meet the criteria for undergoing anaesthesia. A plain film chest X-ray can be performed alongside an abdominal X-ray. However, they need to be indicated for, because you don't want to be exposing a patient to X-rays unnecessarily. And then the last of the acronym is patient understanding and follow-up. So essentially, when you perform a procedure, or prior to performing this procedure, the patient needs to be able to understand what is required of them and why they will be wanting a procedure. So in fully informing the patient of what's happening, understanding an action plan, and discharge expectations can be really good. Some patients expect after surgery to be staying in hospital for over months, when actually the expectation is you'll be going home within the week if everything goes well. Some patients don't expect to be walking after a hip replacement, but actually, according to NICE guidelines, they want patients to be walking within 24 hours. There's better outcomes from it. So understanding and working with the patient, building that rapport to get to a point where they're able to understand the information that you give them, and they're able to look at the leaflets and make their own choice about it. And then you may even consider talking about a follow-up plan if you're a surgeon, to consider whether, if talking about plan B, so if the surgery wasn't to go well, what would you consider? What would we do next? But yeah, any questions? I think that's it. I know that we've gone over slightly longer than expected. We have some MCQs if you guys would like, but like I said, we have gone over an hour. just, would you like, put in the chat, would you like 1 or 2 MCQs? Yeah, okay, fine. I will put, okay, let's do one, you tell me when I think we've got up to 10. So we'll start with the first one. If you can put I'll tell you when to put the answer in chat. So this is the first one. I'll give you like 30 seconds. Okay, so I think a lot of you have answered. So a lot of you have said the general consensus is B, and the answer is B. Yeah, 2 to 4 weeks, especially for an elective surgery. Obviously with an emergency one, you don't have time necessarily to do 2 to 4 weeks preoperative assessment. So next question. Yeah, general consensus is C. And yeah, you would be correct. Pregnancy test, don't ever forget it. Loads of people fail their practical exams because they forget to ask about a pregnancy test. Always, if a woman is of reproductive age and has not mentioned about going through the menopause, always ask to do a pregnancy test. Okay, so A, yeah, you would be correct. So Melampathy, remember, is an observational assessment to see whether there'd be space for endotracheal tubing, basically. Full form? General consensus is C. Yeah. Remember, clear fluids up to 2 hours before fasting. And I think someone mentioned like a weak coffee is allowed as well in the chat, from what I can tell. And then fifth one. Okay, so the answer is B. Yep, you were correct. If that's one of the things that you only take away from this session, then so be it. But clopidogrel needs to be stopped at least 7 days before. Okay. And then this will be the last one. It's a bit more of a, if you can remember it, it's a memory one, this one. I'll wait a couple more seconds. So general consensus is D, and yes, that's the answer. So you're using the formula 4 millimole kilogram per day. Okay. I think we'll end it here. There are more MCQs, so as and when you get the presentations, you can go through those at your own time.